Great. Okay, so thank you very much for inviting me here to speak today. I'm really excited to share with you some of my work on our two brains. So in and on your body right now exist trillions of microbes. So they're covering your eyes, they're in your mouth, they're crawling up your nose and down your throat. In fact, if you're sitting pretty close to someone right now, there's a good chance that you're breathing in some of their microbial cloud. So what I've just described to you is the microbiome. So that is the teeming mass of bacteria that live in, on, and around us. We now know that the microbiome constitutes a huge part of the brain-gut axis. That is a highly complex bidirectional communication highway between the brain and the gut. And we're now just beginning to realize how important this brain-gut axis is for both our physical as well as our mental health. For example, rodent studies have now shown us that we need a microbiome in order to actually build our brain. And this is especially true for emotion regulation and emotion processing regions, such as the amygdala, prefrontal cortex, and also the hippocampus. In rodents, we also know that disrupting the early life rearing environment actually disrupts the microbiome. Although we don't know as much in humans, especially in relation to early life stress, what we do know is that the microbiome is influenced by the parent-child relationship in humans. And this begins in the womb. So the placenta, birth mode, breastfeeding, and skin-to-skin contact all go towards shaping this initial community of microbes in the infant's gut. Now, this brings up a really interesting question. That is, can we treat the gut to address adversity-associated emotion problems in the human? So I address this question by taking a cross-species approach, looking at how caregiving adversity affects the microbiome, the brain, and also emotional behaviours. In the human, the caregiving adversity that I looked at, as Nim has previously described, Dr. Tottenham just described, is that of previous institutionalisation, so children reared in institutions or orphanages overseas. And I then model the parental deprivation component of that experience by looking at maternal separation in rats, where I take pups away from their mother for 3 hours per day, every day, across the first 2 weeks of life. And I use this cross-species model to answer these two questions. Firstly, does caregiving adversity disrupt the microbiome in humans, and how does that relate to brain development and also anxiety? And secondly, can we reverse the effects of caregiving adversity by treating the microbiome and looking at that in a rodent model? So let me first describe to you what we see in our human group. Specifically, we find that early exposure to stress actually leads to a persistent disruption or dysregulation in the microbiome. For example, we see in the comparison group, so what I'm showing you here are the top 30 genera across both rearing groups, with the previously institutionalised on the left and the comparison on the right. And what you can see is that the comparison group has guts that are actually dominated by this Bacteroides bacteria. In contrast, previously institutionalised kids have guts that are dominated by this Prevotella type of bacteria. So we see this persistent change in the gut that's associated with early life stress. The next question we had was, are those changes related to the brain and also anxiety? And to answer this question, I decided to focus on one of these bacteria, particularly Bacteroides bacteria, because it was the most abundantly expressed across all samples, so when we collapse across rearing groups. And the next analyses in the brain that I'm going to show you are collapse across rearing group. So what I find is that the Bacteroides bacteria actually predicts increased medial prefrontal cortex reactivity to fear faces in this emotional faces task in the fMRI, and also predicts increased MPFC to hippocampal functional connectivity. Now, importantly, MPFC to hippocampal functional connectivity had consequences for anxiety. Specifically, we found that increased MPFC to hippocampus functional connectivity was associated with lower levels of anxiety. So this really lends support to the idea that early adversity is associated with persistent disruptions to the microbiome in humans, and potentially in ways that are related to emotion functioning, suggesting that we might be able to target the microbiome in order to treat emotion problems. So I addressed that in the rodent by treating rats with a probiotic as they were being stressed. And I took advantage of the fact that I had already established that early life exposure to stress, maternal separation stress, actually leads to a disruption in emotional behavior. So what I'm showing you here are the behavior of two groups of rats, some that were not stressed and some that were on the left. And these rats were trained to fear a white noise that was paired with a foot shock and were then tested either at 1 or 7 days. In the standard reared animals on the right, you'll see that they're exhibiting good levels of freezing at 1 day and forgetting by 7 days. In other words, they're exhibiting infantile amnesia, which is a typical fear behavior. In contrast, the maternally separated rats, that is stressed rats, exhibit good fear retention both at 1 and at 7 days. So they show persistent fear responses. When I treated maternally separated rats with a probiotic while they were being separated, I actually found that they looked much more like standard reared rats. In other words, probiotics prevented these stress-induced alterations in fear behavior, suggesting that using probiotics in order to address emotional effects associated with early life adversity might be a way forward in the human in the future. Thank you very much.
All right, our next speaker is Emanuela Offedani.
Hi everyone, my name is Emanuela Offedani. I work at the Center for Integrative Medicine at Weill Cornell. Thank you for this opportunity to show you our findings about demoralization and depression during the TRIUMPH trial. So as we heard this morning, African Americans have greater risk of having and suffering from greater risk factor for cardiovascular disease, and they also have worse outcome. This difference, these disparities, is explained somehow by genetic factors, but is also explained by some psychological and socioeconomic factors. We already know the effect and the impact of depression on cardiovascular disease. We less know about another psychological state that's called demoralization and its impact on health. Demoralization is a distinct state that's characterized by feeling of hopelessness, helplessness, and giving up. The demoralized individual feels like they fail achieving a major goal, and they experience a loss of control about the ongoing situation. Put it this way, it's difficult to see the difference with depression, but I'm going to show you later. So the aim of our study was to see the effect and the impact of demoralization with or without concurrent depression on blood pressure control in African Americans who participate in the TRIUMPH trial. TRIUMPH is actually trial using motivational, self-affirmation, and positive affect to increase blood pressure control in African Americans. We compare motivational interviewing and education to motivational interviewing, self-affirmation, and positive affect in African American recruited from different ambulatory practice from Harlem and the Bronx. Overall, both our interventions were successful in achieving blood pressure control in African Americans. About 80% of our participants achieved, actually, at the end of the trial, blood pressure control. However, among the 20% who did not achieve blood pressure control, a major driver were the presence of demoralization and depression. As you can see at the bottom of the table, this is the major difference between demoralized patient and depressed patient. Demoralized patients are usually more reactive. They are able to still experience some pleasure, and their affectivity is higher and almost comparable to people and participants who did not have any psychological distress. What we found is actually that demoralized participants were actually less likely to achieve blood pressure control in a comparable way to demoralized, to depressed patients, and to both participants who had both conditions. And this was true even after controlling for social, demographic, and clinical variables. So the take-home message is that depression and major psychiatric disorder, they're not the only major player in the picture, and we should actually also check for subthreshold at different psychological syndrome in our participants. And also, again, from what we heard this morning and the work of Dr. Jackson, we know that maybe assessing and evaluating depression may be not right target in African Americans. Also, we know that participants that being enrolled in a behavioral change intervention also have more problems if they are experiencing distress, because it's obvious that if you have difficult situation, if you suffer from discrimination or other chronic stress going on, it's difficult to engage in behavioral intervention. So this is a specific and important topic, especially in minorities. Thank you.
Our next speaker is Anna Ortin, who is from Hunter College.
So, yeah, in the meantime, I'm gonna present in a new approach that we are using. Okay. Okay. So I'm gonna explain a new approach that we are using with a team in the New York State Psychiatric Institute to study the development of competence among ethnic minority children. So competence is defined as a pattern of effective functioning in the world in relation to expectation based on norms of behavior in a given context, culture, and time in history. Among school-age children, these expectations, usually defined as a developmental task, are doing good at school, being able to regulate emotions and behavior, and getting along with peers and adults. Development of competence is very sensitive to the influence of the environment. So we think that ethnic minority children are gonna develop competence in a different way than those children that are part of the majority group. And we think that it is important to understand how ethnic minority children develop competence in order to design prevention strategies to prevent disparities to appear. The traditional approach that has been used to examine the development of ethnic minority children is to compare these children with whites that are considered the normative group. However, most of this research has focused on negative outcomes, with ethnic minority children usually showing more problems in mental health and doing worse at the school than whites. The problem of this approach is that it maintains the negative stereotypes that we have of minority children, and also give us few information about how actually these children develop competence. Another problem of this comparison with whites is that the effect of the minority status gets confounded with other variables such as the social-economical status, the cultural values that are unique among the different ethnic groups, and also with the effect of the differences between ethnic groups that usually get collapsed together. So the approach that we are proposing to being able to isolate the effect of being a minority group, so living in a minority context, is to compare children from the same ethnic group, but living in two different contexts that differ by minority status. So what we have done is to examine how Puerto Rican children living in the South Bronx and in Puerto Rico develop competence in the 3 domains that I mentioned before. For this, we are using data of the Boricua Youth Study. That is a longitudinal study that follows almost 2,500 children and families over time. Right now, they are conducting the wave 4 of assessment. So for this research, we are focusing on the first 3 waves of data where children were between the ages to 5 to 13 at baseline, and half of them are living in the South Bronx and the other half in Puerto Rico. So we define the 3 domains of competency, mental health, academic achievement, and social adjustment, and we define different levels of competence based on their performance during across the first 3 waves. So we have children that are always having a good performance over time. Those are the always competent kids. Then we have the never competence kids, and then for the rest of the possible trajectories, we collage them in the unstable trajectory. And we define these trajectories for each one, these levels for each one of the competence domains. So in this figure, you can see the distribution of the different levels of competence by domain, by site. We first observed that most of the children, regardless of where they are living, show competence at some times across the 3 waves, or they are always competent. And we also found that there were only differences by site in the academic and social domain. To further explore these differences, we conducted multinomial regression analysis, and where we compare the never and stable levels with always, and we found that children in the South Bronx compared to Puerto Rico, they were more likely to be never competent in the academic domain or unstable in the social domain. When we broke down the unstable trajectories in the different combinations, we found that children in the South Bronx were more likely to lose competence over time in the mental health in the academic domain, but they did not differ with children in Puerto Rico on developing competence over time, and they were even more likely than children in Puerto Rico to develop competence in the social domain. So the take-home message of this research that we are doing is that the effect of living in a context where the children are the minority group has a different impact on the different domains of competence, and it also has a different impact on when the children develop or lose competence. For example, we saw that children in South Bronx are already, very early on, are already showing not being competent in the academic domain, which should be speaking about the different prevention strategies that we should use with these children. So with this type of approach, we are trying to shift from the traditional approach that is focusing more in negative outcomes to more positive outcomes, and also to really isolate the effect of living in a minority context, that the effect that it has in the development of disparities. And our next step is to identify the risk and protective factors that these children living in the minority context have. Thank you.
All right, our next speaker is Jonathan Rendina from Hunter College.
Okay, so I'm going to be talking about psychosocial stressors and resilient factors as predictors of immune health for HIV-positive older adults. So there's been quite a bit of research looking at psychosocial stressors and their association with health behaviors, and so there's good reason to believe that there may be indirect effects of psychosocial stressors on a variety of immune outcomes for HIV-positive individuals. There's not a lot of evidence, but there is also some evidence to suggest that there may be direct effects of various psychosocial stressors on immune health for these individuals as well as for the population in general. And so, for example, depression has been looked at as something that is associated with inflammatory markers as well as disease progression and CD4 count. And so the goal of this study was to look at some secondary data analyses to look at how psychosocial stressors that are particularly relevant for HIV-positive older adults, loneliness, depression, and HIV stigma might be associated, as well as looking at social support, another big issue for HIV-positive older adults. And so the two outcomes of interest are the two primary immune outcomes for HIV-positive individuals, CD4 cell count, as well as the viral load. And the models adjust for known confounders such as sociodemographic characteristics, as well as the length of HIV infection, their adherence to ARV medications, and their viral load. This comes from a large RCT funded by NIDA, and the principal investigator was Jeff Parsons. This is a study done over the past few years, and it has a large team that are responsible for making it a possibility. And so it was an RCT with 3 arms. It was a spirituality-focused intervention, mindfulness combined with various other spirituality and meditative techniques. And so for this reason, I focused only on the baseline data before people were randomized into the intervention, and I analyzed the survey data in collaboration with the viral and CD4 data. I should also just quickly say it's a study of 119 HIV-positive older adults, all over 50 years old. It's a primarily racial and ethnic minority sample. At least about 85–90% were participants of color. About 33% of the sample were women. About a quarter were heterosexual men, and about 40 to 45% were gay or bisexual men. Also relatively disenfranchised, very low levels of education, as well as low income. And so these are the primary findings. At the top are all of the confounders that I'm adjusting for. This is also a substance using sample, and so I'm adjusting for severity of alcohol and substance use related problems. What you can pay attention to are the 4 variables down at the bottom. That is the 3 psychosocial stressors, as well as the 1 potential resilience factor of social support. I should say the depressive symptoms were measured using the Geriatric Depression Scale because of the sample characteristics. This is a scale that's been validated to measure depression among older adults specifically. And what you can see here is that HIV stigma, much to my surprise, came out as the only significant variable that was associated with these. And one thing that I immediately thought was maybe this is due to some confounding effects. There's probably quite a bit of multicollinearity between stigma and these other variables. It turns out that even in the bivariate associations, HIV stigma was actually the only meaningful variable that was associated with CD4 cell count. And this is adjusting for or over and above the impact that HIV stigma may also be playing on things like adherence and viral load that have been shown in previous research. And so the basic conclusions of this study are that greater HIV stigma is significantly and independently associated with lower CD4 cell count. And CD4 cell count is the type of thing you want to keep high. CD4 is the primary site of HIV infection. It's the primary target of the HIV virus. And so lower CD4 is associated with a whole host of immune compromised situations. And so these findings suggest that independent of known factors that we've already established in prior research, HIV stigma serves as an actual stressor for HIV-positive older adults and should be a primary target of our intervention. So for example, the intervention that this study was embedded in was not targeting HIV stigma at all. And so HIV stigma might be an appropriate target for future intervention development. And also another question that this raises is what is the actual mechanism through which HIV stigma is associated with these immune outcomes? My own research is particularly interested in looking at some biomarkers of physiological stress response, which have been shown to be associated with CD4 cell count as well as viral load, although some previous research suggests that things like depression are not mediated through physiological stress response in their effect on immune health outcomes for HIV-positive individuals. So the question is whether stigma may be mediated by the stress response. And so essentially we need structural and individual level interventions in order to improve HIV-related health for HIV-positive older adults that are a particularly vulnerable population for comorbidities, morbidity, and mortality. Thank you.
Our final Data Blitz presenter is Kristen Riley from Memorial Sloan-Kettering.
Thank you. Wow, thanks so much for these great presentations. We're doing some lung cancer stigma research at Memorial Sloan-Kettering with Jamie Ostroff, so I'd love to talk to you after. So my name is Kristen Riley, and I am a postdoctoral fellow at Memorial Sloan-Kettering Cancer Center. So in the context of all of this fantastic clinical research, we found ourselves thinking a lot about the clinicians. We kept hearing that the clinicians involved in psychosocial interventions were really burnout. They were really tired. They were having a hard time coping with taking care of people all the time. So what I'll be talking to you about in the next few minutes is how to care for the carers of these interventions. So we did a deep dive into the literature after hearing this from our study clinicians, and we found that burnout and high stress is very common for frontline mental health care providers, social workers, clinicians, psychologists, counselors who are interfacing with patients on a daily basis. And the need for brief, low-cost, easily disseminable stress management interventions was really high for this population. They have very little time, especially people working in the ER at hospitals. So we wanted to find a way to embed an intervention in the workplace that was going to be both effective and something that they would want to engage with. So we had done cognitive behavioral stress management interventions previously, these traditional stress management interventions, and people liked them and did pretty well, but when they were offered after we finished the actual intervention research, people didn't really follow up with them very much. So we wanted to find something that was attractive to mental health care providers, and we thought of yoga. So yoga is something that's growing in popularity that currently is really only available to a small subset of the population, people who are wealthy enough to afford those $19 classes. So we wanted to make these available in the workplace to mental health care providers and sort of sneak in traditional stress management intervention components to make these maximally effective and useful for these clinicians. So we developed a yoga-based stress management intervention. And we offered these classes in the workplace, in the hospital system or the counseling center where these folks worked for 8 weeks. And we measured pre, post, and 2 months out. We were able to enroll 40 mental health care providers, and we found that there were really great changes in both groups. So we compared the traditional CBSM, cognitive behavioral stress management intervention, classroom-based type intervention, with this new yoga-based stress management intervention. And we found that both increased a variety of great health outcomes, including fruit and vegetable intake, decreased heart rate, decreased alcohol consumption, increased relaxation response, and decreased stress levels, burnout, and depression. There was no effect on BMI or sleep here. And these are time by group effects. And unsurprisingly, the traditional stress management intervention, the classroom-based one, people showed more increases in coping skills. And then in yoga, more increases in physical activity, also unsurprising. However, yoga was really better at decreasing secondary traumatic stress. So the stress that clinicians face from coping with other people's reports of trauma that actually induce traumatic responses in them. So that was really important. There has not been a lot shown to protect against those effects. And then greater increases in mental health as well. So what we found was that a yoga-based stress management intervention was really great for these folks. They really rated it as much better than the traditional cognitive behavioral stress management intervention. We followed up and folks continued to do the yoga that was offered in their workplace. So the takeaway is that, this yoga-based stress management intervention might have something cool to offer. If you can convince workplaces to offer this type of intervention, people like it, people want it, and it really has great impact and stands up to the traditional cognitive behavioral stress management model. So, thank you.